to be the last speaker in this very rich day in thalassemia and sickle cell disease discussions. I'm going to discuss ineffective erythropoiesis as the underlying cause for anemia in beta thalassemia and the treatment approaches. I hope there will be no repetition. We all know that the thalassemia is a genetic blood disorder. According to the globin chain, which is reduced, it is either alpha thalassemia if the alpha globin chains are reduced, or beta thalassemia if the beta globin chains are reduced. And we know that ineffective erythropoiesis, chronic anemia, hemolysis, and iron overload, they drive the comorbidities associated with beta thalassemia, as well as we know that these thalassemias are classified according to the transfusion requirements into non-transfusion dependent and transfusion dependent thalassemias. And always a multidisciplinary approach is needed. This is the very famous and the very rich figure by Professor Musallam. He has to up, okay, about the classification of thalassemias according to the transfusion requirements, whether non-transfusion dependent or transfusion dependent. And we know that we have the thalassemia trait and thalassemia minor, which are they are not in need of transfusion. Okay. Looking to the pathophysiology of beta thalassemia. In beta thalassemia, there is beta reduction and the beta globin chain synthesis. So there is an alpha globin chains and excess alpha globin chains in the red cells, and this is going to get aggregation into the red cells and form what's called the hemichromes. The presence of the hemichromes, they attach to the red cell membrane. There is an increased reactive oxygen species, and this results in ineffective erythropoiesis, increased apoptosis. The red cells, because of the presence of the hemichromes, this results into binding of autologous IgG and C3 to the membrane of the red cells. So these abnormal red cells, they will be taken by the macrophages in the spleen, so we are having hemolysis, ineffective erythropoiesis. We have increased apoptosis and increased removal of the damaged red cells. The end result is anemia, and this anemia results in increased erythropoietin, and then when you get an increased erythropoietin, this is going to cause more erythroid marrow expansion. You get the skeletal deformities, extramedullary hematopoiesis, and also elohepsidin, and we get increased intestinal iron absorption, as well as with the excess transfusion for the anemia, there is all the complications of the iron overload, in addition to the splenomegaly due to ineffective erythropoiesis, due to trapping of the damaged membrane red cells, and later for hypersplenism. All of these results in the pathogenesis of beta thalassemia. So the anemia and the pathogenesis, it's chronic anemia and hemolysis, it's iron overload, but ineffective erythropoiesis is the core driver of the thalassemia pathology. What's the difference between effective and ineffective erythropoiesis? I'm so sorry, السلايدز بتجري من غير ما ادوس عليها. What's the difference between erythropoiesis, the effective and ineffective erythropoiesis? This is erythropoiesis. It's a vital, lifelong process. It meets the ongoing demand of erythrocytes, maintaining the normal circulating erythrocyte. As in the bone marrow, first we get from the hematopoietic stem cell, and then they proliferate and differentiate through several intermediate erythroid progenitor cell stages. So, and then we get the erythroid progenitor stage, what we call the proliferative phase, or that is the early erythropoiesis phase, and then the phase of where the erythroid precursors, they go into differentiation and then into maturation, and this is what's called the late stage of erythropoiesis. This is what I mean. This is the early stage of erythropoiesis, mainly characterized by proliferation of erythroid progenitors and is under the influence of erythropoietin. And this is the late stage of erythropoiesis, which involves differentiation and maturation of the erythroblasts. So the erythropoiesis is under the influence of a network of cytokines, transcription factor, epigenetic regulators, And the balance of inhibitory and stimulatory regulation results in the steady state erythropoiesis. The most important factors working are, as I said, erythropoietin. It promotes survival of the erythroid progenitors. The GATA1 induces differentiation. It's responsible for the differentiation of erythroid progenitors, delayed erythropoiesis. The growth differentiation factor 11, which belongs to what we are going later on to discuss, the transforming growth factor beta superfamily, it negatively regulates the late stage maturation. It regulates negatively the differentiation phase. The FAST, we know it is a cell death receptor. It is triggered by the FAST ligand. It induces apoptosis and maturation arrest. So ineffective erythropoiesis is marked by increased proliferation, as you see. This is normal erythropoiesis. This is ineffective erythropoiesis. First, there is an increased proliferation of the erythroid progenitors. There is increased apoptosis of the, this is the normal, this is the abnormal. There is increased apoptosis of the erythroblasts, and there is impaired maturation of the erythroblasts. By the end, what will happen? By the end, we are going to get anemia. So in this just cartoon to show the difference between steady state and ineffective erythropoiesis. In ineffective erythropoiesis, there is more proliferation, proliferative phase, less maturation, and more cell death. Ineffective erythropoiesis, it's not specific to beta thalassemia. It contributes to symptoms and complications in patients with different hematological diseases, including inherited sideroblastic anemias, myelodysplasias, congenital dyserythropoietic anemias, hemolytic anemias, like some types of sickle cell disease, in addition to the beta thalassemia. And ineffective erythropoiesis per se in these pathologies, they result into anemia, need for red cell transfusion, iron overload due to the transfusion and due to a low hepcidin, abnormal bone marrow microenvironment with the bone deformities, extramedullary hematopoiesis and hepatosplenomegaly, and also the hypercoagulable state, which is an important marker causing thrombotic events and pulmonary hypertension. In beta thalassemia, the milestones of therapy has advanced over the years since 1970, where we are thinking of safe and regular blood transfusions and iron chelation, with thinking of hematopoietic stem cell transplantation, improving transplantation and iron chelation in the 90s, and then in 2000, oral chelators. In 2010, improving the knowledge of iron metabolism and gene therapy. And in 2020, we have the new erythroid stimulating agents, gene editing and iron metabolism modulating agents are new methods for the control of ineffective erythropoiesis. So when we are going to speak of beta thalassemia, what are the new therapies? Either they alter the alpha beta globin ratio, like hematopoietic stem cell gene therapy or fetal hemoglobin inducers, or there are other mechanisms to reduce the alpha chain synthesis. Okay, they are still experimental and in clinical studies. And there are measures to control the iron overload, like the many hepcidins, hepcidin analogs, and the TAMPRAS inhibitors. And there are a group of drugs working on the ineffective erythropoiesis. This is our topic today. They include the JAK2 inhibitors, the luspatercept, and the sotatercept. If you are going to speak about the JAK2 inhibitors, JAK2 in normal erythropoiesis, physiological levels of erythropoietin induce the phosphorylation of JAK2. When the erythropoietin binds to the receptor, it leads to phosphorylation of the JAK2, and we get the normal erythroid proliferation and differentiation to mature red cells. In beta thalassemia, erythropoietin synthesis is increased. There is a lot of erythropoietin. This leads to activation of the what we call JAK2 state 5 pathway. This induces uncontrolled expansion of early erythroid progenitors. They fail to differentiate and they further perpetuate the ineffective erythropoiesis. This is okay. The importance is there is a drug, the ruxolitinib. It is a potent and selective oral JAK1 and JAK2 inhibitor. It has been approved for myelofibrosis and for polycythemia vera, because it's going to mainly to decrease proliferation. Okay, but what about thalassemia? In a phase 2 study of ruxolitinib in thalassemia, it included 30 regularly transfused adult patients with thalassemia and splenomegaly, and the results revealed that there was, in this study, there was a significant decrease in the size of the spleen, and this is the mean spleen volume reduction from baseline at week 12 and week 30 was minus 19% and minus 26% respectively. However, it did have no influence on the transfusion requirements. So it was said that it is of value in transfusion-dependent thalassemia patients who are having splenomegaly for sustained reduction in the spleen size. However, recently in 2021, this article published in the Pediatric Blood and Cancer showed the efficacy and safety of ruxolitinib in ineffective erythropoiesis suppression pre-transplantation treatment for pediatric patients with beta thalassemia measure. They took 10 patients with transfusion-dependent thalassemia. They give them the drug for 3 months. They found the spleen to be decreased in 9 out of the 10 cases. Among this group, 8 cases went to bone marrow transplantation, and the outcome was favorable in 7 out of these 8 patients. This is a new era which is opened. Other drugs targeting the ineffective erythropoiesis are what we call the erythroid maturating agents. This is the transforming growth factor beta superfamily ligand TRIPS. This family plays a critical role in regulating hematopoiesis in normal and disease states by controlling cellular proliferation, differentiation, and apoptosis. And we have 4 protein groups. As you see, in each group, there are multiple members. There are the activins, the transforming growth factor beta, the growth differentiation factors, and the third is the bone morphogenetic protein. The activins and growth differentiation factors, they have inhibitory effect on the erythroid lineage, mainly on the late stage of erythropoiesis, so they inhibit differentiation and maturation. So in some hematological diseases, overactivation of specific transforming growth factor beta superfamily signaling via SMED2/3 contributes to impaired erythroid maturation, one of the underlying mechanisms of ineffective erythropoiesis. I will explain it. When you have these select transforming growth factor beta ligand, they bind to this receptor, which is the activin 1 receptor 2. When it binds to this, it results in phosphorylation of a transcription protein in the cytoplasm, which is called SMED2/3. When it is activated, phosphorylated, activated, we get a complex. It passes to the nucleus. It affects the nucleus. It affects the genetic signal and inhibits erythroid maturation. So SMED2/3, it inhibits the erythroid maturation. Impaired maturation of the erythroblasts into terminal differentiated results in ineffective erythropoiesis. So the overactivation or dysregulation of this SMED2/3 signaling is characteristic of impaired erythroid differentiation and ineffective erythropoiesis conditions like MDS and beta thalassemia. So inhibitors of this transforming growth factor beta family that sequester, those that sequester the SMED2, SMED3 signal, they are going to remove this inhibitory effect. So they are going to help the maturation of the erythroblast. Luspatercept. Luspatercept is the first in-class erythroid maturation agent. It is a fusion protein. It is formed of like this, a modified extracellular domain of activin receptor 2B and human IgG1 Fc domain. What's the point? This is transforming growth factor family ligand. When it binds to the receptor, it's going to activate SMED2/3, make a complex going to the nucleus, and the end result is suppression of the erythroid maturation. But if you give the luspatercept, it's going to trap this ligand, so the receptor is not activated, SMED2/3 is not activated, and the end result is the relief of this suppression on erythroid maturation, and this favors the differentiation of the erythrocyte series, differentiation and maturation phase. This is typical as shown here. If you are having SMAD signaling, as you see, this is proliferative phase. It's okay, there is no problem. But when SMAD2/3 signaling, it's going to suppress maturation and differentiation, and you get anemia by the end. If you get luspatercept, you are getting less SMAD2/3 signaling, no activation. So you are getting more differentiation and more maturation, and the anemia is corrected. Early, it was thought that the effect of luspatercept was only through the GDF11, but it proved to be other factors like GDF8 and activin B and others. They have a role. This is, I believe, Professor Capellini have made a wonderful presentation today about luspatercept phase 3 trial for transfusion-dependent thalassemia. This is the resume. 336 patients, 18 years or old. They were given luspatercept 1 to 1.25 milligram per kg in 224 patients, subcutaneous, every 21 days for 48 weeks or more. And the placebo were 112 patients. And the primary end results were a 33% or more reduction in the transfusion burden weeks 13 to 14. This happened in 21.4% of patients on luspatercept compared to 4.5% of patients on placebo. And the side effects were transient bone pain, arthralgia, dizziness, hypertension, hyperuricemia were more frequent with the luspatercept group. This is the details of the study. I don't think we have to speak about the details of the study, but the study now is an open label, up to 5 years, open label state. Let's think about the results of this study in very short. This is what I said. This is the primary endpoint, week 13-24. 21% of the transfusion-dependent thalassemia achieved 33% or more reduction in their transfusion requirements compared to the controls 4.5%. If you are going to speak about the secondary endpoints, it's looking to the weeks 37 to 48. At 37 to 48 weeks, the still 19.6% of patients had 33% or more reduction in their transfusion requirements compared to controls. But what about if I'm going to aim higher, a 50% reduction of transfusion requirements? They found that by the week 13 to 24, 7.6% of patients on luspatercept had 50% reduction of their requirements. And this increased to 10.3% by weeks 37 to 48. So its effect on the reduction of the transfusion requirements is very evident, and it is very evident. This is this is additional analysis. They look to any 12-week interval and any 24-week interval. The orange is the group on luspatercept, and the blue, the group, the control group. If you are going to look at the any 12 weeks interval, 70.5% achieved 33% or more reduction compared to 29%. And at 12 weeks interval, 50% achieve, the reduction of 50% or more was achieved by 40% of patients on the luspatercept compared to 6.3% of the controls. When they analyzed the data of the 24-week interval, they found that still 41 patients on the luspatercept achieved transfusion decrease by 33% or more, and 16.5% achieved a decrease in the transfusion requirement to 50% or more. So this is clinically meaningful reduction in the transfusion burden. This was not influenced by the genotype of the beta thalassemia. The safety data were very acceptable. Okay, and this is the Beyond trial. The Beyond trial is about luspatercept in non-transfusion dependent thalassemia. It is phase 2 randomized double-blind placebo-controlled multi-center study to determine the safety of luspatercept versus placebo in adults with non-transfusion dependent beta thalassemia, and they took 145 adults with non-transfusion dependent beta thalassemia or hemoglobin E beta thalassemia, and they randomized to a group who received luspatercept every 21 days plus best supportive care, and a group who received a placebo plus best supportive care. And these are the results. The results have been presented in the European Hematology Association 2021, in June 2021, not published yet. Okay, by the end, 96 patients received luspatercept, adults with non-transfusion dependent thalassemia, and 49 received placebo. Baseline median hemoglobin was 8.2, and look to the results. At week 13 to 24, 77% of patients in luspatercept achieved the primary endpoint, a hemoglobin increase of 1 gram per deciliter or more versus 0% in the placebo. And for the secondary endpoints, at week 13 to 24, 52% of patients in the luspatercept achieved hemoglobin increase 1.5 or more compared to 0 in the placebo, and even 89% of patients in the luspatercept arm remained transfusion free at weeks 1 to 24 versus 67% of the placebo patients, and there was improvement in the quality of life. And in the luspatercept arm, there was no thrombotic or thrombophlebitis manifestations. Malignancy was observed in the other arm, not in the luspatercept arm. And this is another drug, as the sotatercept. Sotatercept is a ligand tribe for transforming growth factor beta superfamily members, but it differs in the composition from luspatercept. It has some specificity related to the bones, okay, improve the bone disease in menopausal ladies. And initially, it was in phase 2 trials, it proved to be effective to improve anemia in beta thalassemia. This was a phase 2 trial, but because the luspatercept is more specific, the sponsor made a decision not to advance trials of sotatercept in beta thalassemia and only to proceed with the luspatercept clinical development program. As I said, the luspatercept is approved by the FDA and by the EMA for the treatment of beta thalassemia patients. Finally, I will go it very shortly. I am speaking about ineffective erythropoiesis. Is there a link between iron and ineffective erythropoiesis? Yes, there is a crosstalk between iron and erythropoiesis. Ineffective erythropoiesis causes iron overload through at least 2 main complementary ways. Increasing bone marrow production of erythroferrone from the erythroblasts, it directly suppresses hepcidin, and it increases red cell apoptosis, so lysis of the abnormal red cells, releasing iron. What about how the iron influences ineffective erythropoiesis? The unlimited availability of iron represents a boost factor for erythropoiesis, and also the iron released within the red cell membrane is toxic. This decreases red cell functionality and lifespan. So multiple approaches have been developed to control ineffective erythropoiesis through fine-tuning of the iron metabolism, and usually they are targeting the hepcidin. And we know that the hepcidin is produced from the hepatocytes. It degrades ferroportin, the main iron exporter, in the intestinal cells, macrophages, reticuloendothelial system, and the hepatocytes. And in beta thalassemia, hepcidin production is inhibited through the action of erythroferrone. So we have 3 groups. I'm not going to tickle it. I have 1 minute. There are 3 groups of these drugs. Stimulators of hepcidin production, okay? This is through working on the TAMPRAS gene. The TAMPRAS gene, which encodes the matriptase, which is a serine protease that inhibits hepcidin. So when you inhibit the TAMPRAS gene, you are going to remove the inhibition on hepcidin, and you are going to cause a rise of hepcidin amelioration in mouse model. This resulted in a rise of hepcidin, amelioration of ineffective erythropoiesis, and iron deposition. And there are 2 studies, one in phase 2 and phase 1 going on. The mini hepcidin, or what they call hepcidin mimetics, they act as hepcidin agonists. Although they they look first like to be very good. The hopes in them were great to cause hematological improvement. However, clinical trial data were not so encouraging. Finally, the ferroportin inhibitors, okay, because the increased absorption or increased release of iron to the circulation is through ferroportin. So ferroportin inhibitors, it's a molecule FIT2763. It's a small molecular weight oral ferroportin inhibitor. In mouse model was found to restrict iron availability. So it improves the erythropoiesis, ameliorated anemia, reversed dysregulated iron homeostasis, and improved ineffective erythropoiesis. The good thing about this molecule is that it works independent and does not interfere with the oral iron chelation therapy. This is a great advantage of this molecule. So by conclusion, an enhanced understanding of the mechanisms of ineffective erythropoiesis and this erythropoiesis allowed identification of new molecules with potential therapeutic effect. Luspatercept is first molecule registered by FDA and EMA to treat anemia in patients with transfusion-dependent beta thalassemia. The control of iron dysregulation in conditions associated with ineffective erythropoiesis could ameliorate the underlying cause of the anemia, including the hepcidin agonist stimulators and ferroportin inhibitors. They could be good candidates improving anemia in ineffective erythropoiesis. And I'm greatly thankful لحضراتكم. ألف شكر.